Good evening, everybody. Welcome to the Oculus Clinical Webinar Series. My name is Dr. Bill Tulo, Medical Director with Oculus, and I'm really excited for tonight's presentation, Why Not Keratoconus, with Dr. Noyes and Dr. Sindt. Before I introduce our speakers tonight, just a little bit of housekeeping. If you have questions, please enter the questions into the chat, and we will save time at the end to answer your questions. Tonight's presentation is going to be fantastic. This is one of my favorite topics, and I can't wait to see what Dr. Noyes and Dr. Sindt are going to present. Dr. Sindt, as everyone knows, graduated from the Ohio State University College of Optometry. In 1994, she completed her residency at the Cleveland Veterans Administration Medical Center. And in 1995, Dr. Sindt joined the faculty at University of Iowa Department of Ophthalmology and Vision Sciences, where she currently is Professor of Clinical Ophthalmology and Director of Contact Lens Service. She also serves as a consultant optometrist for the Iowa City Department of Veteran Affairs Medical Center. Dr. Sindt is Chief Clinical Editor for the Review of Optometry and serves as peer reviewer for several journals of ophthalmology. Dr. Sindt holds 7 U.S. patents and over 150 publications. She's the inventor and founder of iPrint Prosthetics and obtained FDA approval for her process and design, and her designs are now in the global market. Dr. Marcus Noyes completed his Doctor of Optometry degree at the University of Houston College of Optometry in 2018. He then did a residency in cornea and contact lens ocular disease at the Ohio State University Havner Eye Institute in 2019. Since then, he's achieved fellowship in the American Academy of Optometry and a fellowship of the Scleral Lens Society. He currently works as a clinical assistant professor at the University of Iowa Department of Ophthalmology in Specialty Contact Lens Department and is a member of the Scleral Lens Society Fellowship Committee. Without any further ado, Dr. Noyes and Dr. Sindt, take it away.
All right. Thank you so much for having us. This is one of my favorite topics, too. Marcus, we get a lot of patients referred into us, don't we?
Yeah.
And often they come in like, oh, they have keratoconus, and we're like, do they?
Yeah, actually, the cornea department, we get so many referrals. Oftentimes, they have to come to us before to like screen out what is keratoconus and what's not, because we just have so many referrals, like you said.
Right. We're going to, there's a lot of external signs, retinoscopy, all these things that we look at. Today's lecture, we're really going to be talking more about corneal topography and how to screen out for corneal topography, because, I think everything looks like keratoconus on topography. What do you think?
Yeah, I agree, and I think so do most topographers.
I think you're right. I think so. So lots of things to think about. Well, we're really not going to get into most of them, are we?
We'll scratch the surfaces of everything here, at least. Like, of course, the clinical signs here of keratoconus. I'm sure everybody knows a lot of these. Things like Munson signs and retinoscopy reflexes are very common. There's some things like Rizzuto's sign, which people don't really have time to do, but still it does exist. So there's a lot of different clinical tools that people know and see for keratoconus. But let's see how that translates to topography.
Right. Of course, you don't want to ever see high drops. The topographer, man, it's location, isn't it? Where it picks it up and how that topography looks like. All these things really are keratoconus, but it depends on where the thinning on the cornea is.
Yeah, and that last picture there clearly illustrates that inferior knee common with pellucid, with that arrow pointing out where that thinning and inferior knee is, usually within 1 millimeter from the limbus.
Right. And, I think the latter two, if you have a central cone, it could actually make the topography look completely normal, but you could still have keratoconus. And as that cone moves down, or that thinning moves down in the cornea, you get a wider and wider sort of hot spot on the topography until you get that classic crab claw look with pellucid marginal degeneration. But, they're often confused. Those inferior cones in pellucid often look a lot alike on topography, or they're indistinguishable on an axial map. Because to a topographer, everything looks like keratoconus. Right? Have you ever been fooled, Marcus, when you thought something was or wasn't keratoconus, and then it turns out it's something completely different?
Of course, I think we all have, but
Yeah.
that's part of the reason I think this is such a helpful topic is just getting little tips to help screen out. And then the other thing is, even looking at all these maps, we've come a long way with our tomography imaging, even just in quality,
Right.
so that helps too.
Yeah, absolutely. Some of these are from, I think, the early 2000s. So, yeah. So, that brings us to the point. Topography versus tomography, like, where do we stand? What do you need in your practice to really differentiate, these things? Topography is really a 2D information. It projects an image, it reflects back that image, and you're looking at a projection or a reflection from the front surface, and then that is translated into a 2D image. Right? Whereas tomography looks at it in the 3D space. I love my 3D space. I love looking at everything in 3D space. But you got the front surface, the back surface, the anterior chamber, the lens of the eye, the angle of the eye. You can really get a lot of information using tomography. Marcus, you describe what you see on the anterior map, because this is really the one that most people look at, right?
Yeah. So what I would see is kind of first things that jump out is obviously there's a red circle inferior to the center. So kind of like that pattern D that you have listed, or maybe H, something along those lines. Also, I can see there's a dioptric reading of 84.9, which hopefully would send a yellow or red flag of that's not normal. So this at first does look like there's a lot of power in the slightly infracentral area, which would represent or at least set off a flag of thinking of keratoconus or some sort of ectasia at this point.
Right. So, there's these patterns that you can look at. The more symmetric the pattern, the less likely it is to be keratoconus. Doesn't mean it doesn't have to be, but the more symmetric the pattern, the less likely. Or if you start to have a skewed deviation, like in pattern G here. So a skewed deviation, if it's more than 20 degrees skewed, so if you look at this blue line and the red line here, if they're more than 20 degrees skewed, that is more likely to be keratoconus. And sometimes keratoconus just shows up as an irregular pattern, like E here, where it's just something random that it's really hard to describe. So we're looking at that pattern. That's the first thing that I look at. I take a quick look at that sagittal map, and this is a power map, right? This is just telling us rate of change, or how fast the cornea is curvature is changing on it. And so in an anterior map, we also look at the powers, right? So what is that dioptric reading that you brought up there? And Marcus, what is your cutoff for, like, oh, I'm thinking that's keratoconus?
Specifically in dioptric power, you mean?
In dioptric power, yeah.
Yeah, I usually start thinking of it around 47, but probably more closer to 48 is where I'm thinking, okay, there could be something going on here.
Right. Yeah, I have seen 43 diopter cones, and I've seen people with 49 Ks of 49 that don't have keratoconus too. So, it's not hard and fast, but you really want to look at that and say, is it over these? You start seeing greater amounts of cylinder or astigmatism. And we're going to get into some of these other readings here in a second. But as nice as the sagittal map is, it's really the elevation map that gives us our bang for our buck. And that's really the one that I spend more time looking at than the sagittal map. How about you?
Yep, posterior elevation, the posterior float's my first place to start every time. Yep.
Mm-hmm. Matter of fact, I call the sagittal map my money map, and the reason I call it the money map is what I tell patients are: the less green, the more money you're going to spend with me.
I love it. I have adopted that a couple times too.
Just to prep them to get them in the right headspace there. And then they're like, ooh, I don't have a lot of green there, do I? I'm like, nope, you don't. So on this elevation map, you really can't just look at the pretty colors, right? Because I had somebody today that was solid green. The elevation map was entirely solidly green. It didn't have a hot spot on it at all. But yet, when you looked at the deviation from the best fit sphere, he was more than 30 microns. And so you really have to start looking at the numbers too. So what you want to do is look at, you know, these deviation numbers here. These are how far do you deviate from the best fit sphere that's on here. And it will tell you if you have a hot spot, like here's a hot spot and it's deviating about 27 microns. Here is just very regular astigmatism. This is a very normal eye. Both of these are my son's, by the way. It's really not deviating at all there. But anytime you get over about 15 microns on that posterior elevation is when you have to start thinking, I may have some ectasia going on here. This is not normal. Right? Under 15 microns is normal. Now, it takes the anterior elevation a lot longer with somebody to see it on the anterior elevation. So this is the one on the left. Here's my son, Ben, who has keratoconus, but you see it's really not showing up on the anterior map versus my other son who just has very regular astigmatism.
Yeah. Hey, Chris, one question for you there on that last slide. I know like what you were saying, 15 microns, you're thinking you should be raising red flags. Is that specifically when it is not symmetrical? I have a lot of people ask me on like that bottom right map, you know, there's a plus 22 right there, even though it's not irregular. Is that what we're really looking for there, or is there some?
Yeah, we're really looking for a hot spot. You know, something. So the more symmetric something is, this would be represented. If you have a Pringle potato chip on a best fit sphere, you're going to get a symmetrical map. But if you have an irregular shape, you're going to end up with a hot spot. And you can have both an irregular shape and a regular astigmatism in the same patient. So this subject here on the left here, you're going to see these blue dots and the red ones out in the periphery. That's just representing his normal cylinder amount on the back surface of the eye. It's this hot spot here right in the center that is indicating the ectatic, or the as we sometimes call it, the back bowing of the cornea.
Perfect. Yeah, I know that comes up a lot on when I'm talking with people. So great explanation.
Yeah, great point. Great point. Well, in the pachymetry map, I just love this global pachymetry. You know, it really tells us a lot about what is happening on the cornea and where those thin spots are, where those hot spots, if you are. One, you want to look at the pachymetry difference, the superior versus the inferior values, because when you start having greater than 30 microns of difference in the same spot, so this is a 5 millimeter ring here. If you start having a difference in greater than 30 millimeters at that distance, you really need to think this isn't normal, right? The eye should be more symmetric, superior versus inferior. You also want to look at where the corneal apex, so this is the center of the cornea, compared to the thinnest location. And if you're more than 1 millimeter away, it should not differ by more than 10 microns. And so, and that is really an indication of keratoconus in those cases. I also use the pachymetry map for corneal transplant patients, and I look at these isopacks here, and to say do I have any, you know, hot spots that are going the other way, you know, any areas of thickening on the cornea, maybe any areas of edema or endothelial dysfunction as well. Anything to add there, Dr. Noyes?
I do the exact same thing, looking for subclinical edema with Fuchs or with PKs. Also, sometimes depending on the location, you can actually use it to measure Salzman nodules too.
Mm-hmm. Exactly. Yeah. So let's look at this quad refractive map and talk through it. So Dr. Noyes, if this patient showed up, you know, in your practice, how would you walk through this map here?
Well, first off, I would be very suspicious of ectasia right off the bat. First thing that we just talked about is I always look at the back elevation or the posterior float. And just like what you were saying before, there's like a sore thumb hotspot of plus 36, I think it says right there.
Yeah.
Where that is higher than 15 if my math checks out. So I would be thinking that right off the bat. Then secondly, looking at that axial map, we can see, just like we described before, it is not symmetrical. Thankfully, it's not red, so I'm not going to be spending much money, hopefully, but
Lots
definitely,
of green, right?
yeah, definitely not symmetrical though. And then looking down at the corneal thickness there, you can see that there is a large variance between the numbers. I think 539 to 503 right there. And the apex and the thinnest point are separated by, I don't know how much, but at least a bit. And then kind of lastly, looking at that elevation front map, it looks pretty normal, but like we were saying, that is kind of the last thing to change. So someone like this comes in, I'm definitely suspicious for ectasia or at minimum subclinical edema.
Right. When I look at this front surface map is so good. I would think immediately this patient is probably refractable. And so I definitely should check this patient for glasses to get them a pair of glasses that they can wear. I look at the Ks over here as well at 41 by 42. So again, this patient is very, very flat, but yet at the same time, I am very suspicious of keratoconus as well. I then go down and look at the K max, which is in this case 4450, which is much higher than the average Ks on the front. So I look at the Ks, but I also look at the K max on the cornea as well. And then I look at the pupil center, which is 519 versus 501. And so, in this case, I have about 18 microns there between that. So it's more than 10 microns. So I'm kind of suspicious in that case that we do have keratoconus there as well. And then if you look at here at the thinnest location, which is about 0.82, here, anything over 1 is more suspicious for keratoconus, but it's not a hard and fast rule, but it's just a number that you should look at, the farther, where that apex is from the center of the cornea. And then the next thing I do is when I'm suspicious of it, I will look at the Bell and Ambrosio enhanced ectasia display, because this really helps me hone out, do I actually have a problem? And what I'm looking at, the first thing I look at when I look at this is the corneal thickness spatial profile. And what this spatial profile means is really how far away, what's the average thickness at the different zones away from the center of the cornea, and how does that relate to the average person? So in this case, this particular patient really is fairly average with the corneal thickness of his corneal. Nothing on this one stands out that this patient is particularly thin or particularly thick based on a population of patients, a normal population. But what does stand out is when you look at the percentage of thickness increase. Now, what is the percentage of thickness increase? What this is saying is if you start at the thinnest spot and you look at what's the percentage of change across compared, how much are you changing compared to that actual spot that's in the center of the cornea, not compared to other thicknesses, for example, but comparing it to itself. How does that change? And you're going to notice here that we're really at that edge for keratoconus. We are changing out into the periphery. The percentage of change from the center to the periphery is indicative in this case of keratoconus. You're outside the normal rate of change. So the cornea is within normal thickness tolerances, but you're outside of the normal rate of change from the apex to the periphery of the eye. So that is making me think, maybe I have some keratoconus here. Then I look at the left-hand screen here. And what I'm looking at here is this right-hand column is the front surface elevation. And the left-hand column is the front surface elevation, and the right-hand column is the back surface elevation. And what we look at here is you have a best fit sphere. So what's saying is all the points on the cornea, what's the curve that best fits through all of those points? When you go down to the second image here, you say, you know what? I'm going to exclude the hot spot. Let me take this out, this little hot spot here out. And how does the best fit sphere fit here compared to the rest of the cornea? And how does the best fit sphere here compared to what this best fit sphere was up there? And here's where you get the difference map. And it says, if you had two that were the same, everything would be green. And the farther apart the best fit sphere is here, from here, the hotter this color is going to be. And so you see that in this case, that back surface cornea, you really do have a difference. And it's like putting up a yellow flag here saying, hey, and a little bit of a red flag, this is probably something ectatic. This is abnormal. Whereas on the front surface of this patient, it's completely normal. So we've got a problem with back bowing. We have a problem over here. The other things that you can look at here are these down here. So this is saying, what's this difference map on the front surface? Is that first one, that's the DF, and this one's normal. This is absolutely normal. When this is looking at what's the difference map, and this is saying, no, I'm throwing up a yellow flag here. The next one here, the DP, is saying, how different are we from a normal pachymetry? And this one is throwing up a red flag. So between these, you can say, how abnormal is this patient? So overall, this is throwing up a flag saying this patient probably is abnormal. This patient probably has keratoconus or ectasia in that eye. So even though the front surface map, so in this particular patient, you may not have even been flagged using the axial map, because it's a little abnormal, but not dramatically, certainly not by the case. But when you actually look at these keratoconic measurements, you say this is probably a keratoconic patient. Okay, so these are the numbers that I look at when I'm looking for whether somebody truly has keratoconus or not. But, we get patients that get referred into us all the time, with a diagnosis of keratoconus or with suspicion of keratoconus. We have to determine, is that actually the problem? So Dr. Noyes, when you have somebody that comes into you with a complaint of really bad glare and LASIK, and they've had LASIK surgery, keratoconus is probably pretty high on your list, correct?
When people come in with bad glare after LASIK surgery, first thing on my mind is dry eyes, LASIK surgery, just in general.
Yeah.
But we do see it.
Yeah. So these are her sagittal maps. What do you think about those? What are you reading those as?
Well, just like we were kind of saying before, there is that in non-symmetrical view right off the bat. There's that inferior steepening that looks like it's present, and then also the angles of the meridians. They look at first glance like they're way off, but as you dive a little bit deeper in, the numbers look pretty similar overall.
Mm-hmm. We've got a little hot spots here. This is like 45-ish, almost 46-ish down here, in that range. But definitely, it looks like you have a hot spot, right? It looks like there's something going on there. We could probably explain her glare. Let's look at the quad map. So let's go over here and look at your elevation map, Dr. Noyes. What do you see there? It's pretty good, right?
Sorry, got me a drink of water. Yes, it looks pretty good.
Yeah, I see a lot of regular astigmatism, and I don't. To your point before, you got a blue up top, blue down on the bottom, little, but it looks symmetrical. There maybe there's a little hot spot here, but is there? The other thing that I look at is when you see it's only 8 microns. When you see a hot spot, go up and look and see if it's in the same place as the elevation. If it's not, it's probably not ectasia. Okay. So you see how the hot spot on the sagittal map is inferior, the hot spot on the back elevation is temporal. So it's probably not ectasia there. And then when we go over and we look at the pachymetry map, there really is no deviation from the center of the cornea to the thinnest location on this cornea. There's no deviation, so it's not separated by any amount. And the corneal pachymetry, the pupil center is 523 microns, but the thinnest local is 522 microns. Okay. So overall, and our isopacks are very symmetrical around that pupil center, so we don't see a hot spot on this cornea. So what do you think now? What are you thinking? We've got this sagittal map that looks funky, but I'd say the pachymetry map and the front and back surface elevation maps are normal. Yeah, what do you think now?
I'd be thinking, obviously, irregular astigmatism as a broad term, but yeah, also could be. I'd be curious to see how the LASIK flap is doing.
All right. So in this particular case, let's look at the Bellin-Ambrosio ectasia display. Everything is normal. If you look at this, the difference maps are normal. The corneal thickness profile is normal. The percent thickness increase is absolutely normal. There are no flags down here with any of the difference maps. So this is really saying this person does not have ectasia. Okay. Now, there's part of the story that I didn't tell you, but this person truly was referred into me with the diagnosis of keratoconus or post-LASIK ectasia. This is her other eye, by the way. So you can see the same thing happens on this eye. Again, regular astigmatism on that posterior, regular astigmatism on the anterior. No differences with the sinus local 0, 0. No differences in pachymetry. Pachymetry is quite robust, totally in the normal range there. So again, we've got this irregular astigmatism on the front surface, but no indication of irregularity here. Now, what I didn't share, I didn't want to give it away at first, is this particular patient has congenital ptosis and has had several frontalis slings done to lift those eyelids up. And what she has here is a congenital, and this happens a lot in our patients that have congenital ptosis, is there's a lot of weight on the upper globe from that eyelid. And so just like a beach ball, if that upper eyelid is pushing down, it's pushing the cornea out inferiorly. So she does have a power change on the front surface of the cornea, but a change in curvature without any ectasia at all. The treatment is actually scleral lenses. We did put her into scleral lenses, which actually opened up her eye a little bit more. She was super happy with the cosmetic effect. And the over time of wearing the contact lens, she actually, I'm sorry I don't have a photo of it, she actually became more normal in her topography because the scleral lens was protecting her cornea. So,
awesome.
How
Great
about your case?
Yeah, this is a case that I had, which was a 70-year-old female who came in basically she was referred over for a scleral lens evaluation was all that I got out of it. Her symptoms were blurry vision and glare, kind of the classic 1-2 punch, and best corrected vision in the notes from the previous doc was 20/50. So first thing we did, of course, is do the Pentacam. And right here, looking at it, some of the things that jump out is there is kind of that sore thumb appearance on the hot spot on the posterior float, and it's highly irregular too. However, looking at the axial map, it looks kind of all over the place, almost like that, I think it was letter E on the previous slide, where it's just kind of crazy. It doesn't really look like there's like an inferior steepening point or anything. But just from looking at this initially, first thought was this could be some sort of ectasia or keratoconus, even despite there being low K values, with I think the K max is 45 on there. Mm-hmm. However, sometimes you have to dig a little bit deeper.
You know, what stands out to me here is you've got these little islands on the front surface, 1, 2, 3, 4, 5 little islands there.
Yes, that's one of, spoiler alert. Yeah.
Yeah. Should I stop talking? Because I don't know this case.
That's good. That's good. We can take it this way. So yes, there are some, you would thankfully notice that the elevation front map, which we said normally looks pretty normal in keratoconus, looks a little funky. So that
right.
could be a clue. Yep.
Mm-hmm. And so here we're a little bit thin in this particular area here. You're about 1.3 millimeters away here from the apex of the cornea, and your top spot is, well, you're about 20 microns from here to here. So you do have some ectasia in this particular area of some sort.
Some sort of BS thinning, or perhaps, but yep.
Yeah.
So this is when she came back from slit lamp photos, this is what it looked like. And of course, the first thing I had to remember to convince myself is this is not corneal hydrops. This sometimes comes up from referrals or things. You see some sort of scarring with a weird Pentacam or a tomography map, and all of a sudden you think you've got keratoconus or hydrops. But however, if you'll continue there, this is actually corneal lattice dystrophy type 2. There's the linear branching opacities, kind of ropey looking, and there are some versions, most people think of this as being congenital, but there are some versions that don't really appear until the 4th decade of life. So I have those areas just highlighted with the yellow arrows there. Though, yep, that's obviously directly pointing to the scarring and opacities, but the one to the left there, you can see almost in the retro or the sclerotic scatter that they light up pretty easily. So that's kind of another way to help justify those ropey branching lattice structures.
Yeah, and sometimes when you have a lot of scarring or some really, really dense areas on the cornea, the pachymetry, the global pachymetry will come up looking thinner than it actually is, just because of the way the light passes through the cornea.
Yeah, and then so basically, where do we go from here? Educated this patient, and especially with lattice, this is something that can progress. I always try and get ahead of things, saying that it could possibly become surgical in the future, but stick with me. Let's try one of these crazy contact lenses. So we ended up fitting her in a scleral, and she actually got to 20/30. You can see the fit looked really good. We did an impression-based fitting here to make sure that she would have the best possible vision and optics. But able to avoid a transplant and continue with 20/30 vision, I was shocked.
Yeah, and when you look at those Scheimpflug image or the OCT image on these cases, you'll see that these granules are really limited to the more front area of the cornea. Usually the patients get a lot more comfortable in the contact lens as well. But you'll be able to pick up these opacities on the Scheimpflug image as well.
Yeah, so just to even jump on that a little bit more, so exactly what you're saying in that box number 1, you can almost see the whiteness or the grayness in the middle goes almost all the way down, but halfway, and then it looks dark on the bottom half on the peripheral edges of that photo. That's what you're talking about. It's kind of limited to that anterior stroma. Exactly.
Yeah.
Great. Another case. Yeah, this is another one. This is a really interesting one. I had a 52-year-old female come in with high myopia, and she was one of those people that you can tell is visibly anxious in the chair, like she's twitchy and looks like she's gonna cry and all this stuff. And she told me that when she was a kid, she was told she would go blind. And she mentioned hearing keratoconus and all this before, and it basically caused like a phobia of eye doctors. So it had been 30 years since she had come into the eye doctor. Yep, she was buying her contacts illegally to try and have some vision, but it wasn't going well, so she finally gave up and decided to come in. So her best corrected vision initially was 20/40 and 20/25. You can see her quad map or her fore map there. Looking at the axial scan, definitely irregular. Looking at the back posterior float, not really any huge hot spots jumping out. It's fairly symmetrical, I would say. What do you think, Dr. Sindt?
I think it looks great. I mean, it's what, 12 here? Yeah, it looks really good.
Yeah.
That doesn't concern me. The front elevation doesn't really concern me either. That looks pretty good, pretty symmetrical.
Also pretty symmetrical. And then Packy looks good too. I think we got her at like 517. Is that what that says?
Yeah, 517. And the apex is pretty right on to the center of the cornea, or the thinnest area. So it all looks pretty good.
Absolutely. So this is like what you don't want to see, because now nothing makes sense. Why is her vision bad? So continuing on here, this was her slit lamp photo. And as I hope, like me, you're looking at this saying, why am I looking at this? It's a normal slit lamp photo. So continuing on again here, this is her other eye, slit lamp photo and map. I'm not going to go through this super in depth. It's kind of the same as the other one, symmetrical for the most part, normal packies, K's seem fine, all that sort of thing. Slit lamp photo looks normal as well. So
does it though? Does it?
Well, maybe let's zoom in and look a little closer. So when zooming in using kind of that diffuse or parallelepiped slit lamp beam, you can see this cloudy crocodile-like pattern in the center of her pupil. That is not indicative of ectasia, but is indicative of another condition called central cloudy dystrophy of Francois. Basically, a rare dystrophy that has a lizard-like pattern with gray stromal opacities, sometimes called central or posterior crocodile shade green. Usually these patients are asymptomatic, but there are case reports of them having just mildly reduced vision, which seemed to be the case in this case. So here's that same picture again. I put some arrows there just to highlight where the red or orangish arrow is. That's the cloudy crocodile-like shade green part. Hopefully you can notice that. But the yellow arrow above, and there's also below, is completely clear. So that would be the difference between this and like the classic peripheral crocodile shade green. This one is only centrally and spared as you move into the periphery. So for this patient, this was a fun one once we figured it out, because I got to reassure her she's not going blind. This is not typically a progressive condition. Also, I got to tell her she did not have keratoconus, which was extra fun because she had spent her basically last 30 years researching keratoconus, cowering in a corner, I guess.
And what is she going to do for fun now?
I know. And then to make it even more crazy, I fit her in regular soft contacts, but instead of like buying them on the black market, I guess I did a little bit better. And she actually got 20/25 in the right eye and 20/20 in the left. So she went from thinking I was going to tell her she was going blind or has at least a rare condition to actually getting pretty normal vision out of things.
Yeah. And told her she has even a rarer condition.
Even rare. And actually, I did tell her that, and she was so excited. She was like, if you're going to do research, let me know, et cetera, et cetera. So made a lifelong friend out of it.
Yeah, good. Yeah, you'll never lose her. Okay. All right, that's awesome. So this is an interesting case of the 60-year-old gentleman presented to me with complaints of decreasing vision for about the last year and a half. And he has a brother with keratoconus, and his father is an optometrist. So they were very concerned about keratoconus. He saw a local doctor who said, you definitely have keratoconus, and come to the University of Iowa so they can talk to you about corneal transplants. So the patient shows up, and his vision is about 20/25 and 20/20. And he shows up, this is the topography, the axial topography that he came with. And, you'll notice here is he's got a little bit of a hot spot. It really is right in the center of the eye. The white line is his pupil. It's really right in the center of the eye. His Ks are, around 45 or so. Nothing on that topography excites me a whole lot, but you can see it's got a red spot. So red spots are always keratoconus, right, Dr. Noyes? And so here is his Scheimpflug image. I always like to look at the Scheimpflug image because sometimes, if you have, I like to look to see if there's cataract. I also like to look to see if there's a spike in the densitometry. I just take a quick peek at it, right? Because sometimes you'll see, when you have scarring or you have issues, this densitometry goes up, right? And it makes me think maybe I should look at the densitometry map and say, is there something that's kind of getting in the way here, or something that's blocking the vision? So you'll see this is really this little spike right here. It's really epithelial. So the epithelial surface in this area is there's something going on there, and I probably should take a look at it. So then I jumped to the quad map, and this axial map, yes, we do have a hot spot. It's a little bit of an asymmetric bow tie, but it's kind of a weird asymmetric bow tie, right? It's like up, like the hot spot is up, not down. Now, I have seen superior keratoconus. I really have. I had a patient recently. You were there. Yeah, a patient recently was eye rubbing and rubbing the inferior here and ended up with superior keratoconus. But I'll tell you what, I have been in this business for almost 30 years, and it is exceedingly rare. It's like hen's teeth, as we said around here, to have superior keratoconus. But so this would be a rare presentation. Now, when you look at the back elevation map, again, if you look at the numbers, there's nothing on here that is over 15 microns. So even though there's like almost a little hot spot here, or you could convince yourself that there's a hot spot here, the numbers really don't support it. Also, you want to look at where that hot spot is in comparison to where the hot spot is on the sagittal map. They should line up if it's keratoconus. The front surface elevation is non-contributory. If you look at the back surface here, we're at 137 versus 123. So we're really not that much off from the apex to that periphery as well. So can you convince yourself? You might be able to talk yourself into, well, this hot spot is where this hot spot is, and maybe I've got something going on, especially if you really want this to be keratoconus and you really want this to be the diagnosis. But again, this should trip you up. You should be looking at this superior one going, there's something that's not quite right. It doesn't, the parts aren't quite getting together there. So you should keep an open mind. And then when you look at the ectasia display here, it really, your back and your front differences are really quite normal. Your CTSP is normal. Your PTI is normal, and all of your things. You've got kind of something going on, right? But all of your ectasia references here are really falling into the normal category. So again, you got something going on, but it's not ectasia. Okay? So let me give you a little bit more history. I purposely withheld the history because as soon as I told this to you, you'd know what I was talking about. But this patient presented and he said, now mind you, he came in thinking he needed a corneal transplant for keratoconus. He had a finger poke to the eye about a year and a half ago. He woke up the next morning with a painful eye and blurry vision. And for the last year and a half, he has continually woken up every once in a while, every couple months, with a painful eye upon wakening. And this sort of mild, his vision isn't quite right. Now, I have seen people present with their first diagnosis of keratoconus in their 60s, but it is also very, very rare to have that happen. And so, of course, you all know the diagnosis as soon as I said finger poke. But when you look at the cornea, you can see he's really got this epithelial disruption here, where you see the epithelium just is not tacked down really well. And again, you've got the map dots on the front of the cornea, exactly in the same spot as that hot spot on the anterior elevation. But here's the cool part. When you remember, I alerted you to that densitometry, that you've got something going on there. When you look at the densitometry map, you can see exactly where that is. Now, I don't have video on here, but you can grab the layers here and move up and down through the cornea. And what you'll notice here is this is only located in the epithelium. As soon as you get deeper into the cornea, there is no change in the density of that cornea. And here you can see those areas on the densitometry map in the color display there as well. So, it's a very handy way of differentiating. Did I have keratoconus? But I convinced myself that's a hot spot. Let's look at the other maps and see what is going on. And you can see definitively here that this is not keratoconus. Now, I sent this patient out to a doctor local in his area who did a superficial keratectomy, and all of this went back to completely normal. And he just sent me the loveliest letter thanking me for standing my ground that this was not keratoconus and getting him the treatment that he needed.
Hey, real quick on that last slide,
yeah.
One thing I just want to, again, point out quick is a lot of these findings that can affect things like the central cloudy dystrophy efferentia or like EBMD can be very subtle. So in that far left picture there, you can see, again, you have a wide, bright beam. So if something's looking weird on the tomography, instead of doing that optic section that you're so good at just flipping through all layers of the cornea at, widen that out and you can see things like EBMD and some other rare conditions that could get you an easy way to pick that up.
Yeah, nothing actually replaces actually looking at the patient, does it?
No. Weird how that works.
Weird how that works. Okay, so this is a 16-year-old male from Zambia who was referred to the university by an outside doctor and at the school's request. And he was his concerns are he has very poor vision with light sensitivity in both eyes, and his entering visual acuities were about 2100 and 2500. And, here is his Placido images. And, we really don't discount looking at the actual Placido image because it can give you a lot of information. And one of the things that I noticed on this is just how incredibly ovoid, but how incredibly regular these Placido images are. So this is the map that he came with. Does this axial map stand out to you, Dr. Noyes? What does it look like? Looks like
First
a really
glance,
unfortunate prescription.
really. I mean, it's symmetrical like we were talking about. One thing that may jump out is, that 49.5 or 50 diopters does seem a little steep, but it doesn't look too crazy to me.
Right, it looks pretty regular though, right? Look at that prescription. That is a very unfortunate prescription. You can kind of understand where his vision challenges come from, huh?
Yeah, he's
and so
$8 a cell with the rule. I mean, you'd kind of expect a map like that.
Right. And, if you look off axis a little bit, it can really, with these axial maps, these Placido disc axial maps, you can really change the curvature value of these maps, especially when you have that much astigmatism. He didn't have any stria. He had no Fleischer's ring. He had no apical thinning. The cornea, and you can see here is the cornea. The cornea really looked very, very normal. But you can see a very regular cylinder on this, even though the Ks are quite high. No real hot spot on the back surface of the cornea here, nor on the front surface. This really looks almost very, very like regular astigmatism. But the cornea is quite thin, 470 microns, but it's not a lot of difference between the apex and where the center of the cornea is either on this particular patient. But when you go to the Bella and Ambrosio ectasia display on this particular patient, what you're going to notice here is he stands out for ectasia on almost every single one of these different maps here. And when you look at the percentage thickness increase, you're going to see that he really does stand out. So he's thin overall, but within normal limits of being thin. But how he changes from the center to the periphery is quite abnormal and really stands out for that ectasia. And when you go back and you actually look at the Scheimpflug image, you're going to see that change, the thinning here to the thinning in the periphery. You really can see that stand out on the Scheimpflug image as well. So this is one where really nothing really looks like keratoconus except for that ectasia display. Then when you go and you look at, so with him, we actually went ahead and did aberrometry on the patients because I find aberrometry is quite helpful in some of these cases. And you're going to notice all of this horizontal and vertical coma. And in those cases, when you have all this coma, you really do need to be thinking keratoconus. So surprise, in the why not keratoconus, this is a patient whose axial topography didn't look like keratoconus, but he actually did have keratoconus for this particular patient. So this is how I write my assessment. And let's open it up for questions. By the way, this is my map. If you want to break it down, you're welcome to look at it.
Unfortunately, it's green, so I guess I don't want to fit you. No, I'm kidding.
You don't want to fit me?
Yeah, I'm just joking.
Guys, great job on presenting some really fascinating cases. I think it's really important that even if a patient enters your practice with a diagnosis of keratoconus, that you really substantiate that diagnosis. I think we've all seen patients misdiagnosed and labeled and traumatized sometimes with these labels when they don't actually apply. One of the things that I wanted to point out that I thought that was great that you did is you showed that the Bell and Ambrosio enhanced ectasia display, while it was originally designed to screen refractive surgery patients for abnormal eyes, you showed a lot of examples where it found abnormalities, but they weren't keratoconus, because that display was not designed for finding exclusively keratoconus. It was to rule out all abnormal corneas for refractive surgery. So I think this is the first time that I've seen in a single presentation excellent examples of cases that could look like keratoconus but really aren't. So really congratulations to you guys for putting those cases all together at once. I really enjoyed that. So I have a question for you. Are there any other ancillary tests that you guys rely upon? I know we don't have genetic testing available like we did a year ago, and but besides OCT and tomography, are there any other things that you utilize to help either rule in or rule out the condition?
Well, I think oh, sorry. I was going to say aberrometry is the big one that jumps out to me, just like that last case was signifying. And this is something that there's also a lot of research coming out on. Some studies are even coming out saying that aberrometry can be as specific as 80% and sensitive as 90% for even differentiating between form fruste and full-blown keratoconus. So I think as we get better at that and get better technology and learn more about it, that's going to be a huge advantage for us.
It also really, yeah, I agree. And it also really helps us look at the prescriptions when you look at the prescription in context with the aberrations that are there, you can hone in on a better prescription for the patient as well. Because even if it isn't keratoconus, you're still going to have to come up with a reason why they may not be seeing and correct for that vision as well. So aberrometry is probably the biggest thing that I'm seeing in my practice that I'm doing right now. I never did rely much on genetic testing. I'll tell you, I have a son with keratoconus, and I have 3 other children. I have a young son, an 8-year-old, who is an aggressive eye rubber. And he came back, he screened negative for keratoconus. I'll tell you what, as this mama, it did not make her feel better. And I screen him every 6 months with tomography to make sure that I'm not picking up any early signs of keratoconus on him.
Excellent. I think he's very fortunate that he has a mom who knows so much about this, that will certainly monitor him extremely closely. You both talked a lot tonight about irregularities in corneas, specifically asymmetries. Can you talk a little or mention a little bit about asymmetries between fellow eyes, between right and left eye, and the significance of that with this condition?
You know, I actually had a patient today that was a perfect example of that, and I didn't think we had time to put it in the lecture, but I can include that in one in the future. My patient today had an axial map, sort of like mine here, where it looked a little bit asymmetric, but everything was lovely in green and blue, and it was lovely shades of green. And really all the other maps looked fine as well. But then when you looked at the other eye, you could definitely see that there was a little bit of ectasia on the posterior float on the back elevation of the other eye. And so we came to the conclusion that he did have an exceedingly mild ectasia on the left eye, but that this was probably more of a form fruste type of presentation. And so I always do compare the 2 eyes, and really if I start seeing more than, say, like 20 microns difference between the 2 eyes, I'm highly suspicious that there is something going on between those corneas.
Yeah, and the only thing that I would really add to that is we get a lot of referrals where someone will say, oh, they know something's wrong, but my doctor told me this eye's messed up or something. But then when you do something like a tomography scan, you can pick up keratoconus in the other eye, or maybe it still looks normal. And even if it does, I'll tell the patient, hey, listen, while unilateral keratoconus is possible, it's most often asymmetric but bilateral. So just the fact that one of your eyes is doing good, unfortunately, doesn't mean that you won't develop it, especially in our younger patients.
Yeah, I always tell my patients that it's a bilateral condition and they're just a good eye rub away of having it in both eyes. Get their attention, right?
And speaking of eye rubbing, can you guys give any advice to the other clinicians out there on how to effectively get your keratoconic patients not to rub their eyes? Because I've seen a lot of failures in this area. Do you have any tips that you can give us?
You can't take something away from somebody without giving them something else to do, right? And so first of all, I empathize with the patient, and I tell them that I understand that eye rubbing feels so good and that they want to eye rub and that I get it. And then I give them the reasons why they can't. And then the saline vials, I tell them, get these saline vials, carry them with them, put them in the refrigerator. And when they want to rub, they should squirt their eye out instead of rubbing. And it gives them something to do. It makes them stop. It takes that sensation away that they want to rub. I also look at their lids, make sure that we've got good lid hygiene, that we don't have something else, hanging onto them. But I think that our keratoconic patients, their eye rubbing is really triggered by these incredible sensations on their cornea, this tingly feeling, this nerve ending feeling they have. And they will literally rub to drive it up the pain scale. And that's where I think the pressure comes in for how they rub. They'll drive that up the pain scale. So I make sure their allergies are treated, their lids are treated. But it's really those day vials. They will often tell me that is the single best thing that I've heard is squirting those eyes out. Do you have other tips, Dr. Noyes?
I actually do the exact same thing. Did I get that from you, or is that just separate? I literally tell them keep their saline vials in the fridge.
Yeah, I don't know. I've been doing it forever, so
yeah.
I don't know.
Well, I either learned that from you, or we just randomly separately did it. But yeah, I do the exact same thing.
You probably heard it in a lecture.
Yeah, there we go. I heard it in a lecture.
Well, I want to thank both of you for an incredible presentation tonight. I thoroughly enjoyed this, and I want to thank everyone for joining us tonight. Recordings will be made available in about a week, and I want to wish everyone, again, a wonderful evening. And again, Dr. Sindt, Dr. Noyes, thank you so much.
Thank you.
Thank you, Dr. Tulo. It was great to be here. Thanks for having us.
Have a good evening, everybody.
Thank you.